Just so, dear friends and my dear students, in continuation of our teaching classes, today I have the pleasure of introducing Dr. Nikhil Gadial Patil. Dr. Nikhil S. Gadial Patil is a DM medical oncologist, and he is going to talk on newer advances in medical oncology. And before he proceeds with the topic, let me have the pleasure of introducing him. He's got a rich experience of 10 years, and then he did his DM medical oncology from Tata Memorial Hospital, and then MD General Medicine from St. GS Medical College and KM Hospital. He's also, to his credit, he also did his DNB from the same GS Medical College, KM Hospital. He's got rich experience as a medical oncologist and presently working in Yeshwada Hospital, Somajgoda, Hyderabad from April 2010. And he's got a lot of, his main special interest and expertise is in hematological malignancies, immunotherapy, solid tumors, pediatric oncology, precision oncology, breast cancer, lung cancer, colon cancer. He's got professional membership in American Society of Clinical Oncology, European Society of Clinical Oncology, Indian Society of Medical Pediatric Oncology, Indian Cooperative Oncology Networks, and a lot of research and publications. If you go on enumerating, I think it will take not less than half an hour. So I leave it here because already we are delayed by 10 minutes. I now request Dr. Nikhil S. Gadial Patil to proceed with his talk.
Good afternoon, everyone. I hope I am audible to everyone.
Yeah.
Thank you, Dr. Balaraju, for this kind introduction, and thank you for the opportunity for today's presentation. I think this is for the first time I'm contributing to this wonderful meeting, which involves students and something which I'm extremely happy to be part of. Just to brief about myself, I am quite privileged to be working at Yeshwada Hospital as senior medical oncologist for last more than 10 years. And today's discussion is all about recent advances in medical oncology. Let me share my screen before I get going further. I think I need a permission from the host to share the screen. Is it possible?
Yeah.
No, I think my host has disabled my screen sharing, so I need help on this one actually.
I think nobody, I think, is anybody joined from Karnataka?
So,
audible, please.
Yes, I need the permission from the host. I'm not too sure who is the host currently as a part of this.
From Karnataka.
So can they permit me to join the meeting? I mean, at least can share the screen so that I can share the screen.
I'll just speak to Manjula. Sir, be on the
Yes,
line.
I think I got it.
I just speak to the people on phone and then find out.
I got it. Got it.
Got it.
Is my screen visible to everyone?
Yes.
Okay. Is my presentation also visible?
Yes.
Yes. Thank you so much. And sorry for the glitch. So today's topic is quite interesting as far as a medical oncologist is concerned, and for that matter, all the students. Now, what has happened in the last decade or so, or more than that, I would say from the time I entered the medical oncology curriculum, the things have changed quite dramatically, especially in terms of the various modalities of treatment which are available to us, and also about the understanding of oncology science has improved quite tremendously in the last decade and a half. So When I joined initially, I believe the only drugs which were available with us were mostly cytotoxic chemotherapies, and there was just a bit of a beginning about the use of targeted therapies in that during those times. But in the last few years, there has been a flurry of new advances, especially in the form of targets, precision oncology, also in the form of immunotherapies, new drug technologies, drug developments, also in the form of newer drug delivery systems. And so this area has become quite interesting, especially in the last few years. And that is something which I would like to recapitulate in this particular discussion. So this is going to be the flow of today's meeting. I'll ponder a bit about precision oncology, or also we fondly call it as personalized therapy. And that is something what we are really looking into each and every patient when the patient really comes and visits us in our office, how the things have changed over here, what is a targeted therapy and how the targeted therapy has evolved, what are the common examples, and how really do they work, and what outcomes we normally expect, and what happens in the patient. Definitely a bit about immuno-oncology. Now that is a big buzzword in the field of medical oncology for that reason. How to really rev up the immune system so that the immune system starts working against cancer cells. And that has really changed the way we look at the cancer management. And that has been a real paradigm shift in terms of treatment management. And last but not the least, I'll also dwell a bit on cancer genomics, because that's the next big thing for us. We are not looking at a cancer as one disease anymore. Just to give an example, like a breast cancer is not one disease anymore. But there are hundreds and thousands of subtypes, and how we really look into the cancer as such these days is what is going to be the part of my today's presentation. So this is where we all began. I think we all know these two scientists. Most of us might have read the books of Dr. Goodman and Gilman in the pharmacology. And this was one of the first, I would say, evidence or earliest evidence when somebody tried to use some kind of a chemical drug to work on some kind of a on certain kind of cancer, that sulfur mustard gas. That was way back, almost I would say more than 100 years ago. And from that point in time, we have definitely come a long way in terms of our understanding about the oncology science. And that is what exactly I'm going to take you through this presentation. As we understand, and especially something what we are all are aware of it, that not two patients are similar. It means that not one size fits all. And it is very important. It is very important for all of us to understand. I think I'm getting a lot of disturbance. Can someone look into this? So uh, as
Yeah, I request please somebody is that switch off their mute their mics.
Uh, Thank you, Dr. Balraju. So as we understand, one treatment will not fit all, one issue does not fit all, and that is something has been evident in the last decade or so, especially when we realized that when you talk about treating a particular disease, let's say for example breast cancer or lung cancer, previously what we used to do, we used to give all the patients maybe doxorubicin or cyclophosphamide as a standard of care. But with more deeper insights about the cancer and the way that these cancers or subtypes behave, now that cannot be the case anymore for any of the cancers, and that is something is quite interesting to see. And just to throw more insights over here, when you look at the left part of my slide, and here you realize that this is typically what is called as traditional medicine, something most of us are aware of, that a cancer treatment in general requires, I would say, quite a coordination between the few fields, that is surgery, radiotherapy, and medical oncology field. And we definitely are aware that what chemotherapy does is just that these are kind of a set of cytotoxic medications which attack the fast growing cancerous cell and destroy it. But at the same time, as a bystander phenomenon, a lot of normal cells also come under pressure, and that is quite evident in terms of the side effects when we talk about the chemotherapy administration. So this is more, I would say, a traditional way of treating a cancer patient. And what has happened in the last few years is more about the era of precision therapy. So when you talk about the targeted therapy, the target means it's just to identify certain kind of a gene or certain kind of protein on the cancer cells or in the cancer cell. And if you really identify that particular genetic or proteomic abnormality, is there any way to specifically target that particular gene or protein so as to uh, have the desired effect in terms of the cancer management? So that is all about targeted therapy. I will definitely discuss a bit more about immunotherapy. So let us talk about what is called as targeted therapy. Again, as we understand, chemotherapy can kill both healthy cells as well as cancer cells, whereas the targeted therapy will definitely try and identify only those cells which express certain proteins. Let us say, for example, in terms of lung cancer, there is one protein which is quite evident and identified is, or I would say much famous, I would say here is epidermal growth factor receptor, that is also called as EGFR. So if a cancer cell harbors this particular gene and eventually also develops that kind of protein onto the cell surface, and if you have a target which are anti-EGFR targets, then these medicines can selectively bind to this particular set of cells, and that can lead to the eventual apoptosis of those cells. So just to give further clarity what exactly happens, a target therapies give you very specific disruption of the pathways. Vis-a-vis when you talk about chemotherapy, it's more like a carpet bombing, and that leads to is myriads of side effects what we typically see with the chemotherapies. And that is one of the reasons why the targeted therapies are quite gentler to the patient, and very specific side effects are expected. Some of the important examples to really give over here is definitely one is we all know about the disease called chronic myeloid leukemia, CML. And CML is one of the typical, I would say, pioneers in terms of when you talk about the targeted therapies, especially when you know that BCR-ABL is particular protein which is responsible for the eventual upregulation of the cell cycles, and to really target this BCR-ABL with a drug like tyrosine kinase inhibitors like imatinib, dasatinib, nilotinib, bosutinib, so and so forth. So all these drugs have made a massive difference in terms of the patient outcomes. And just to give an example, in 2000 odd, this drug was initially launched, and I would say even in the today's date, almost 85%, that is in 2 decades, almost 85% are continued to survive, uh, especially with these targeted therapies. So these targeted therapies have real massive impact onto the cancer outcomes. Another important example I would say is the target which is identified as HER2, which is on the breast cancer, and we all might have heard about a drug called Herceptin or trastuzumab, which is basically anti-HER2 antibody, and that has again led to the way we probably plan and treat the HER2 positive breast cancer. Remember, HER2 positive breast cancers are quite aggressive cancers, and to really negate that aggression, one needs the addition of another target called trastuzumab. Another example I would say is in the colon cancer. So there are many examples in this field where the targeted therapies have contributed exceptionally in terms of the outcomes of the patient. So when we talk about targeting cancer therapy, we always mostly as a clinician or clinical oncologist, we are more concerned about the predictive outcome. When I talk about the predictive, it means that which particular protein we can identify on this particular patient so that which particular drug can be used. So that is what is called as predictive. Yet there are certain prognostic markers. For example, I would say maybe KRAS or BRAF. Now, these are adverse prognostic factors. It means that if you identify a certain protein, you actually determine the prognosis of the patient as an adverse one. So these targets can work as prognostic markers. They also can work as predictive markers. And also there are certain markers, biomarkers, which can also tell us what is going to be the adverse effect profile of the patient. So it is quite interesting to understand how we look at this science in the current era than what we used to see all these years together. about a lung cancer, see, this is how typically a lung cancer understanding has evolved. I am sure that most of us probably would have gone through their during their pathology or internal medicine training that initially the lung cancer only were divided as a non-small cell and small cell. Eventually, for non-small cell, we again had a discussion about squamous versus non-squamous. Again, in the non-squamous, we again had a squamous non-small cell genomics, where we also had could come across squamous, non-oncogene addicted, and oncogene. Now, what I just now discussed about this oncogene addiction is one of the classic examples. Just now I discussed was EGFR. Then there are certain immune driven, and as of now, if you really look at the Bayer diagram of the non-small cell lung cancer genomics, you will come across at least 50 or 100 gene signatures, and each and every gene signature probably may have a totally separate group of drug. Some gene signatures may not have as of now therapeutic implication, but the way we look at these cancers, we all surely know that this is not a one cancer anymore. So there are patients in our practice who, despite giving minimal treatment, do exceedingly well, and there are certain patients who, despite giving the best of the treatment, may not do as well. This all happens because of these prognostic biomarkers, which really hamper the outcome of the patient. So these are quite important targets as we see over here. The EGFR we already discussed. So we have a medicine for EGFR. We have medicine for BRAF. We have medicine for HER2. We have medicine for ALK. For that matter, ROS1, RET, NTRK. So all this MET amplification, exon skipping, 14 exon mutations. So all these mutations we actually are right now identified targets, and these targets are all approved in the clinical practice by US FDA. So it is quite fascinating area, especially for medical oncologists when you really come across these patients. And these are quite common. Now, please understand the EGFR positivity rate in the Indian context is almost 40% for non-small cell lung cancer. It's quite high as compared to Caucasians. So almost 40 to 45% of all our lung cancer patients will be having one target or other. And as a clinical oncologist, it's our job to keep on hunting those targets and then try to find a suitable drug for that patient. And that is probably what we are looking at in terms of treatment. Just to give an example, I think you can really see this particular patient. So this patient again was a non-small cell advanced lung cancer, EGFR mutation positive. And here, as you can see in the upper frame, you can see the patient had definitely much more disease. And post-treatment, as you can see the comparison as I show in the lower half, there is a definite shrinkage of the tumor size as this patient received a drug, first generation tyrosine kinase inhibitor over here, and that actually leads to much of a symptomatic improvement in their patient's long-term outcomes, survival, and that is quite heartening to see in the day-to-day practice as of now. Another example is a colorectal cancer, that there are a lot of again the receptors or proteins which have been identified, but some of the important ones are definitely we use a lot of anti-EGFR, and we also use a lot of anti-VEGF, and also sometimes we also use anti-HER2. So these are common. These are the other mutations, what hedgehog, notch, and other things which we still need to really have a potent targeted therapies. But again, the CRC, colorectal cancer, is also a very important area where a lot of targeted therapies are used. In a brief, what happens when we use a targeted therapy? Now we all understand that there is a receptor which are basically is a basically a protein substrate protein substrate which has got basically three components. Here you can see there is one extra cellular component, there is one transcellular component, and there is one intracellular component. So there are certain antibodies which bind to the extracellular, and there are receptor tyrosine kinase inhibitors which are mostly in the form of tablets. They bind this intracellular component. So when you inhibit this receptor, which are basically responsible for the cell proliferation, you really hamper the cell proliferation by inhibition of this receptor. And once you do that, you also inhibit the downstream activation pathways, and that eventually leads to subsequent apoptosis, anti-angiogenesis, and anti-proliferation, and that subsequently leads to the cell apoptosis and cell death. So this is in brief. I will tell you that if you take any of the targets, most of the targets work on various, I would say, intracellular components or extracellular components, but the pathways remain more or less similar with slight differentiation. Now coming to the immunotherapy part of our discussion. Now we all know body has immune system which is always there for majority of the patient in a very much active state. So in general, when a patient gets a cancer, it is quite logical that this immune system should also act on this abnormal cell and try to throw it out. But what exactly happens is these tumor cells produce some kind of proteins and which basically bind to these T lymphocytes and they shut down these T lymphocytes. So just to make you understand further more here, that these tumor cells mask themselves in such a way that our normal immunity does not identify these cells as bad cells or abnormal cells, and that is the time that these tumor cells escape our immunity and start proliferating in the body, and that is the time eventually the patients develop cancer. So there is enough evidence that once we are able to inhibit this inhibition of tumor cells to of T cells by tumor cell, we can actually end up activating the T cells, and that will lead to flooding of the T cells into the tumor milieu, and that will eventually lead to the immune attack on the tumor cells. And that is how the basic, I would say, the mechanism of how the immunotherapy works over here. So it very selectively kills the cancerous cells over here, and it basically activates the immune system. Either it activates the immune system from outside of the tumor, and so that the lymphocytes start flooding the tumors, or within the tumor itself, where again the cells start again really getting activated and start acting against the cancerous cells. So when it happens outside the tumor milieu, then we normally it's basically done through the CTLA blockade, that is cytotoxic T lymphocyte antigen 4. I'm sure we must have learned at some point in time in our pathology times. Quite difficult to remember, obviously, but these are two important, I would say, short words. What we really need to know that these are the two ways only we normally rev up the immune system, so that the cells, the tumor cells or tumors are start getting flooded with these lymphocytes, activated T lymphocytes, and that lead to real mass destruction of the cancerous cell. Now remember, most of these immunotherapies either are used in alone or in combination with the chemotherapies, and that is quite important. Another way, what we discussed in the previous slide was this one, where the tumor inhibits the T cells through this PD1, and if you block PD1, again there is activation of the T lymphocytes. Again, a very interesting example over here. This is one of the breast cancer patients. Here you can see on the left hand side, this patient had a large lesion just a bit in the retrosternal area. And here you can see a lot of this patient also had a lot of liver metastasis. This is post treatment, roughly I would say around 4 months, and you can easily make out that the tumors have shrunken, or I wouldn't say shrunken, they almost disappeared after the use of immunotherapy. So that's quite fascinating to get responses in certain patients like this. Obviously, it doesn't happen with all the patients, but approximately one third of patients will respond that dramatically. And that is quite interesting when you talk about immunotherapy. This is another patient of metastatic renal cell cancer. Again, this patient had a large, I would say, paraesophageal mass. Also, this patient had lung metastasis. And again, here you can see pre and post immunotherapy, you can see the definite difference in terms of the tumor volumes. And that is again quite, we often see such responses in patient in our practice. But when we know that immunotherapy takes help of the immune system, so this patient goes into basically what is called as hyperimmune state, or I would say autoimmune state. And when you have an autoimmune state, you are expected to get more like an autoimmune phenomena in the entire body. So like we understand like a joint, like a arthritis or autoimmune neuropathy, autoimmune colitis, nephritis. So just like you just open your textbook of autoimmune diseases, and you will, I'm trust me, you will get each and every adverse effect on a different scale. I would say not as frequent, but these are the common adverse effects what we're expecting when we talk about the immunotherapy. And there are certain specific algorithms what we are supposed to follow to really negate those adverse effects and yet continue with the immunotherapy in this group of patients. Uh, immunotherapy discussion may not be complete with the very important advent in the recent times, especially when we talk about immunotherapy, that is CAR T cells, chimeric antigen receptor T cell therapy. One can also say that it is a living therapy which is basically administered in a patient. What essentially happens, it's quite elegant picture over here. In clinic, the white blood cells are collected and the rest of the blood is returned back to the patient. Then an inactive virus used certain kind of genes to insert into the T cells, and these T cells eventually will have these proteins which are produced onto the cell surface, and these modified T cells now are what is called as CAR or CAR T cells. They are multiplied in a million full times. So these we have got a very big dose of now immune activated T lymphocytes which are modified and which are all set to attack onto the cancer cells. And once you eventually pump those blood cells back to the patient's host, or I would say the host again, all these receptors again will bind to the target, that is cancer cell antigen, and that will lead to eventual destruction. Now, this is something what has been one of the most fascinating recent advance in the field of oncology, more so for ALL, acute lymphoblastic leukemia, and certain relapsed and refractory non-Hodgkin's lymphomas. As of now, we are not doing it in India, but it is around the corner. Most of the patients undergo this treatment either in US or sometimes in Singapore. These are quite expensive. I would just give an example. This treatment costs roughly in the tune of 5 crores to 10 crores easily. So it's quite expensive. But that's certain treatments come with the cost for sure. And I'm sure as our understanding improves more and more here, I'm sure the cost is expected to come down in the near future. So from treatment from, I would say from precision to immuno-oncology, let us try and understand how we are now trying to discuss or trying to identify or diagnose or follow up the patients. It's quite interesting to do a liquid biopsy these days. So there are times, there are occasions where we are not able to find a biopsy for whatever reason. Either the patient is far too sick or the tumors are quite deep-seated or where you cannot reach by the needle. And there might be many other possibilities also. In such scenario, there is always this new phenomena called liquid biopsy, which comes quite handy. The basic premise of liquid doing a liquid biopsy stems from the fact that our blood or plasma, for that reason, uh, consists of the DNAs or circulating tumor cells which are shared by the primary tumor. And can we identify certain proteins in the blood, and especially in the form of again certain targets? Just now we had discussed about a couple of targets like EGFR or LK. Can we identify the same targets also in the blood? And that is something what we are already started doing in our clinical practice, especially for lung cancer, where we try and identify certain mutations like T790M on the blood. In the breast, we look for certain mutations like PIK3 kinase. So these are all can be picked up on the blood almost into the tune of 80 to 90%. Suppose for whatever reason, if these reports are negative, then one may have to go for eventually for the solid biopsy, which at times can be quite difficult. Whether it's a tool for screening, as of now, no. Whether people are studying this tool for as a liquid biopsy for screening cancer, it means that if even before the primary cancer is evident in the body, can we pick up cancer cells through screening through liquid biopsies? And a lot of research is going on, but as of now there are no guidelines as such. At times we diagnose patients, of course very uncommonly. Staging, yes, obviously sometimes staging and prognosis. Just to give an example, if you find a circulating tumor cell in the liquid biopsy, and in future again you repeat the same liquid biopsy after 3 months after therapy and the cells disappear, then you do know that these patients are is a responsive patient, the outcomes will be better. And vis-a-vis when the cancer circulating tumor cells number goes up despite therapy, then you know that this patient outcome is going to be poor. So it has some prognostic implication, although they need to be validated further in this situation. Therapy selection, as I already discussed, certain proteins if we can pick up on this one, and if the biopsy is negative, but these liquid biopsies are positive for EGFR, LK, ROS1, then one can actually decide the treatment. A brief about peptide receptor radionuclide therapy is again coming quite a big way in the field of oncology, especially the nuclear medicine. I would say that this is a more of a field of nuclear medicine. What essentially they do is basically they identify a receptor, then they identify a proper target, and they tag that target with the radioactive particle, so that as soon as the protein binds to the receptor along with the target, it causes a local destruction, and that insight is quite interesting way of treating that cancer. Now, this is something what we are already doing in our practice, and very much at our center is the like lutetium 177 lutetium treatment, where one can actually, if one can really, if let us say in this particular slide here, you can see an example of neuroendocrine tumor, and if there is a somatostatin receptor which is identified, and if you get a somatostatin with a somatostatin analog which can bind to the DOTA, to the lutetium, which is basically a radionuclide material, one can actually get a big response, something like this. As you can see in a serial setting for the same patient, how quickly this patient had responded. Remember, this is a typical patient of neuroendocrine TM who received gallium dotatate uh, from September. In a span of less than 15 days, we could also already document some responses in this patient. And eventually, as you could see, subsequently in one other month's time, majority of the tumors have disappeared. What are the spots you can see in the extreme left? That is a C column, are basically kidneys and a spleen, but not a disease. So these are very elegant way of treating the patient, and we get sometimes quite a brisk response. And there are certain diseases like metastatic castrate-resistant prostate cancer. Here again, you can see how this particular patient was struggling with a studied disease, even initially when he after he ran out of the other treatment. And this patient was treated with the lutetium 177 prostate specific membrane antigen therapy. And again, you can see quite a nice response in this group of patients. And we know that when a patient gets a radiological response, in general, they also do get a lot of clinical response. Most of their pain disappear, most of their organ functions improve, and they definitely feel better in terms of their general well-being. About certain new drug delivery systems, now we traditional drugs we all are aware of, we all must have heard about drugs like cyclophosphamide, doxorubicin, cisplatin, and so on and so forth. What are the new things which are happening? Now, a big thing which is happening is the nanotechnology. What essentially happens is all these drugs, not all drugs, there are a few drugs which have been identified, and at their nanoparticle level, they are coated with some protein called albumin. And what we know that albumin has a much better penetration through the vascular endothelial cells into the tumor milieu. So when you have a better drug penetration because of the albumin, we actually are expected to have better responses in this group of patients. So this is again something what we are doing in our clinical practice, to use lot of nanoparticles, albumin-bound nanopaclitaxel, and there are people who are developing who are also using docetaxel and gemcitabines. So it's just a better drug delivery of the tumor, and that will itself lead to better outcomes with a lesser side effects, especially for example, I would say breast cancer and lung cancer, these are rampantly used, these particular drugs. And there is again a very interesting way of treating the patient is what is called as targeted chemotherapy. So we talk about targeted therapy, we talked about chemotherapy, and we are talking something about the targeted chemotherapy. And one of the classic example is TDM1, that is trastuzumab emtansine. Here, as you can see in this particular green receptor, so in this particular, this is basically, let's say this is a trastuzumab, and through this trastuzumab, they attached one small chemotherapy molecule right in the center of that particular protein. And as this receptor identifies HER2, as we already discussed previously, that trastuzumab is an anti-HER2 antibody, the same drug, same protein, that is trastuzumab, carries the chemical or medicine or chemotherapy along with it, and directly sits onto the cancer cells. So again, what happens? There are better responses, there are lesser adverse effects, and there are even definitely better outcomes in this group of patients. So TDM1 again is an approved drug for the second line HER2 positive metastatic breast cancer. Again, we do is to use this particular drug quite often in our system. A brief about HIPEC. HIPEC is hyperthermic intraperitoneal uh, chemotherapy. So what essentially it means that this is not a chemotherapy only. This has combination of chemotherapy as well as surgery. So you know certain examples like pseudomyxoma peritoneae, or maybe sometimes colon cancer with extensive peritoneal metastasis, and sometimes the ovarian cancer. So what essentially happens is these patients usually have only peritoneal only disease. So basic understanding of HIPEC is that when you really do a good cytoreductive surgery, remove as much, I would say, tumor as possible. That is what we call as optimal cytoreduction. Once you achieve optimal cytoreduction, and when you really push in hyperthermic, means the temperature goes up to the tune of 42 degrees Celsius. With higher temperature, the penetration of the chemotherapy into the peritoneum is much better, and that leads to the even better outcomes of this patient in this set of patients. So again, at our center, we are routinely doing, of course, not very common. These patients are quite hard to find and quite challenging at times in terms of their fitness, but their outcomes are definitely superior in certain subset of patients, especially when we talk about pseudomyxoma peritoneae, where the entire abdomen is filled with the gelatin-like material. A brief about cancer genomics. We already discussed a bit initially what bit of a targets, but when we talk about cancer genomics, it's a quite a vast area to discuss as well as understand. What typically happens is, see the cancer gene, if you really try to map the cancer genome, it's become to a very tedious and extensive exercise. And sometimes, despite doing the exercise, one may not be able to identify a target. Yet a lot of work is going on in this particular field, and that is something I would just like to highlight in the next couple of slides. So what essentially it is done is that let us say this is something what we normally don't do in our practice, but let us give an example of Western countries where as soon as the patient comes, in their initial part of their tumor assessment, as soon as the biopsy is done, the entire genomic profiling of the tumor is available for the treating doctor on the, I would say, on the day one of treatment. So by the time all the information, the good, bad, ugly about the cancer is all available. So all those decisions about treatment planning are quite nicely made at the quite early part of the treatment. So somatic genetic assessment versus germline, all everything can be really be seen at some point in time, and preferably to be done early. What typically happens in the Indian setting is that we do cancer genomic sequencing, generation sequencing, it at a later date because these are quite expensive tests, and not all patients can afford this test. But these are the typical patients who are advanced metastatic, who had failed a couple of lines of therapy. These are the patients we definitely try and understand the cancer genomics. And again, the very reason why we do it, so as to understand their prognosis and any possible implications of therapy. So when we look at cancer genome, these are the certain things which we really look at. Now I am talking both from the research point of view as well as from the therapeutic point of view. As a clinician, we are more interested to understand what are the drug targets. Can we monitor certain cancer burden? Let us say the genomic burden is high and whether it is coming down or not. We also need to understand what are the drugs which may work or which may have a resistance. So these are the important areas. As a clinician oncologist, we definitely look into those areas for sure, more often these days than what we used to do a decade ago. And this is something which is happening quite frequently. So in the same breath, let me talk about the precision oncology is nothing but again extension of the cancer genomics. So essentially, which is the best treatment for our patient after so cancer genomics is nothing but the entire kundali of the cancer, I would say. And once you have all the information on the table, and then you take a call about how is the treatment is going to respond, whether this patient is expected to have early resistance or not, what is prognosis, how serious is the cancer, and survival rates. So all this information is eventually going to be available for us for most of the patients. So I won't be surprised in the next decade or so whenever I get a new cancer patient, and I will probably have the entire cancer genomics in the patient's file in addition to the histopathology report, so that the treatment decisions can be taken in addition, not only from the clinical point of view or just the stage point of view, but also from this important aspect of the cancer, that is precision oncology. Not only that, there is again an era of artificial intelligence. Now there are a lot of debates over here. Will the computers take jobs of the doctors or not? There are a lot of studies which are going on where a lot of data is fed into the system. All the reports are fed into the system, and the system comes back with the entire report or the planning of the patient in terms of the treatment. Now that I believe you must have heard about the IBM Watson. They are really doing. They have been working hard on these particular areas. There are equal proponents as well as opponents of this particular doctrine. Having said that, technology is good, but at the same time, it requires a lot of coordination between the doctors and also, for that matter, this AI. Otherwise, uh, cancer cannot be treated by just sitting on the desktop, and that is probably my perception as of now. You need that human touch, you need that understanding, especially when you look at that one particular patient, what he needs, rather than just putting the data to the computer and waiting for the results. Having said that, this is again happening, and you can again see that the system, I would say, various meetings are again flooded with a lot of data presentation in terms of AI in this group. A small word about radiotherapy. I think many of you might be aware of something which is not. I'm telling you something which is really new, but how we really need to treat the patient in the past. As you can see, the center red dot is a tumor, and a lot of normal tissue used to get radiation in the past. So that used to come with a lot of adverse effects. As we are moving beyond 2000, and now you can see that the amount of radiation what we are giving to the tumor, and for that matter the normal tissue, is extremely small. It just tells you that how precisely we are treating the tumor and how well we are preserving the normal tissue. So that has been, I would say, a basic planning for each and every radiation patient these days, and that has definitely really helped in terms of treatment patient management and their outcomes and their functions. Just to give an example, if you treat a head and neck cancer patient with radiotherapy, and if the salivary glands gets a bit of radiation, this patient will have xerostomia for rest of his life. Now, in the today's era, we can actually save the salivary glands, and still patient can get the desired radiation dose, and for that matter, desired outcomes in terms of the cancers. Robot, yes, robot also are coming big way in terms of the cancer therapies. Our surgeons are quite excited about using robot also in the oncology. More so, I would say as of now, there is a bit of data for, I would say more about prostates. People are trying to use robots on almost on all fronts. We do understand that the robots gives more dexterity to our oncosurgeons. So especially for a disease like prostate cancer, where you require a lot of dexterity, a lot of angles, a lot of 360 degrees angles, these are the areas where the robotics have made a big difference for sure. Apart from that, in general, most of the cancer surgeries are done in a open way, because a surgeon requires a very wide field in terms of the operability. So it is still a building up for sure. Robotic surgeries are definitely building up in the field of oncology, and it should also have its own space as we move forward. So this is what typically going to happen to our patients as they come to hospital in the near future. Already it has started happening at few centers, especially those academic centers. As the patient comes, once the patient gets diagnosed, the tumor tissue will be archived. It will go for next generation sequencing. Also, blood sample will be collected, check for the ctDNA, cell-free DNAs. Not only that, with the next generation sequencing and personalized therapy database, this entire data will be fed. Eventually, there will be a lot of information which will be churned out of it. All this information in the form of clinical report will be presented in a tumor board meeting, where the medical, radiation, surgical oncologists, the genetics, the pathologist will all sit together and decide what is the best possible treatment plan for this patient. And that is probably is going to be the future, I would say, in the next, probably I must say, maybe by the time probably I may retire after maybe a couple of decades. I think by that time this probably is going to be the new normal at the time when we are going to think about treating the patients that way. So what are the things which we expect in 2021 and beyond? we expect more utility of genetic genomic clinical assays targeting hard to treat cancer. There are certain really, I would say, Achilles heel like cancers like glioblastoma multiforme, pancreatic cancer, which are definitely an oncologist nightmare where the outcomes are extremely poor. Then we do get a lot of genomics which are unknown significance, variations of unknown significance, also called VUS. So what is their outcome? What is their understanding? Liquid biopsy already discussed. I already discussed about AI in terms of digital pathology, where the slides will be read by the computer system directly, and it may so happen, and people are already developing algorithms on that front. Having said that, these AIs still are far from taking away jobs of the doctors for sure. It can only complement, but it cannot replace the current system. So this is just to summarize what I had discussed in the last, I would say, half an hour or so. Uh, I must tell you that it's quite an exciting time to be a medical oncologist, especially when you look at the amount of research which is happening in the field of oncology and for that matter medical oncology. Trust me, when you look at any of these journals or any of the research which is happening across the globe, almost 70% of the research happens even in the field, even now in the field of oncology, because we are far away from the cures as of now. Hence, the research is quite happening at a breakneck speed. So a lot of research is happening. So a lot of new things are coming up, and a lot of new ways of looking at the same disease all the time. So we will have eventually from a people would be writing in terms of their in front of their degrees, like I am a precision oncologist or I'm an immuno-oncologist or a molecular oncologist. It is quite expected to happen as we go through in the next decade or so. As said before, it quite has happened with me also, that the way probably I used to treat a patient maybe a couple of years back, and the same patient, same kind of patient coming back to me this time, and my treatment approach is quite different, because in a year or so the science again has advanced quite a bit, and that is also exciting, and that's also the challenge for medical oncologists to keep updated, abreast with all the knowledge all the time. But yes, that's quite fascinating to really be part of this particular journey. And as I had already discussed, the targets have where the, I would say, the ruled the last decade. The IOs, immuno-oncology is ruling this particular decade, and so that for a matter genomics. So all these three taken together probably will rule this decade and beyond, and probably maybe after, maybe I would say in a next maybe decade or so, one may see very few patients who are actually undergoing those typical cytotoxic chemotherapies with the hair fall, with the neutropenia, with the mucositis, and probably most of these patients probably go on one or other therapies like targets or immuno-oncology as we look at the next decade and beyond. So with this, I stop here, and I thank you so much for inviting me, and thank you, Dr. Balaji, for this kind of opportunity. I'll be happy to take any questions.
Thank you, Dr. Nikhil, for your excellent, very informative talk, both students' point of view and then the other consultants. And it's really very much informative, and then students might definitely will make use of this. So now it's open for students if they have any questions to be asked or clarifications, and then if you want to contribute something, you are also welcome. So I request Dr. Nikhil to take over and then to answer the questions if there are any. So, we have not got any question on board. I think there are no questions now, I think, but it's a good talk on milestones, and then even most of us who are not exposed to this sort of teaching, especially in oncology, and we have really enjoyed your talk. Once again, I thank you for sparing your valuable time. And then if there are no further questions, I think we will call it a day and then close the session.
Thank you so much. Thank you.
Thank you very much.